heart disease is narrowing of these arteries that supply blood to the heart muscle. But if you have an acute reduction in blood flow, that's called acute coronary syndrome. And when it happens acutely, the heart has no ability to compensate for that. Okay? And the hemodynamic consequences are quite impressive. So a very good example of acute coronary syndrome is a patient who shows in the emergency department having a heart attack. So in a heart attack, a minor plaque in the artery, which typically doesn't cause symptoms, will rupture. And when the artery ruptures, you'll form a thrombus on the area where the plaque ruptured, and that will acutely stop blood flow in the coronary artery. An acute drop in blood flow in a coronary artery results in a myocardial infarction, which we can see on the ECGs. Does anybody know what territory of infarction is happening on that ECG that I'm showing?
It's the inferior.
It's an inferior. It's a right coronary infarction that's happening. So these type of syndromes don't always cause cardiogenic shock, but I'm going to, for the purposes of our talk, go through an extreme example of a heart attack. A patient who's got such a drop in their cardiac function that they're having problems that are affecting the flow volumes. Okay, so we'll walk you through that. So a patient who has a heart attack becomes very, very sick and is having severe chest pain even after we open the artery. The reason that this can happen is that the flow to the heart muscle itself. So let me stop and actually say it a little bit more simply. So each time the heart beats, it ejects blood. Your systolic blood pressure is supplying your whole body with blood pressure. The diastolic blood pressure is actually what's supplying the heart muscle with blood. Okay? Because when the heart is squeezing, the muscle is very stiff, so no blood can get into the heart. Okay? The blood only gets in the heart when it relaxes. So your diastolic blood pressure minus the pressure inside the chamber, that difference is what drives the blood in the heart muscle. So there's a gradient between your systemic diastolic pressure and your left ventricular diastolic pressure. That gradient is what supplies muscle with blood. And that gradient can be impacted by one very common thing, which we talked about. Would it be preload, afterload, or anatrophy? What would affect this pressure right here, the left ventricular diastolic pressure? Preload, right? So if you overfill the left ventricle, if I overfill this chamber, then the blood coming back doesn't have enough of a gradient to fill. So if this curve goes up, then this gradient will become smaller. There'll be less flow to the coronary artery. So anything that I can do to underfill this chamber will allow more blood to get into the muscle itself during diastole. Hopefully, does that make sense what I'm saying? Yeah. So one of the devices that's commonly used to help with this is an intra-aortic balloon pump. Have you all seen that, or are you familiar with that? So this is a device that's placed in the thoracic aorta, and it inflates in diastole. And the reason you want it to inflate in diastole is we want the left ventricular, the systemic diastolic pressure to rise. Okay. The reason we want it to rise is that will make this line higher. If I can make that line higher, then the gradient is bigger, so there's more flow to the coronary artery. Okay? And the other thing that you want to do is you want the balloon to deflate in systole. And why would you want the balloon to deflate in systole? What does that do to the parameters we talked about? If you deflate the balloon in systole, it reduces blood pressure, reduces afterload. So by doing that, if it deflates in systole, it actually creates almost a suction, so it pulls blood forward in the aorta, and it allows that door to open easier. Okay, so the heart has to work less hard. So you can reduce oxygen demand by reducing afterload, and you can improve coronary perfusion by increasing diastolic blood pressure. Okay, so you can get more oxygen to the heart muscle, and you can reduce the amount of oxygen your heart muscle requires with one device. Okay, and so this is a very common device that's used to help stabilize patients who are having acute coronary syndrome. And probably the most common device used in the world. It's very cheap, very easy to deploy, and it's very, very effective because of these hemodynamic principles of preload and afterload. But there are going to be situations where a patient is very unstable and getting even sicker, and we just cannot get them stabilized. And so there are other devices that we can use. So there's an axillary flow pump called Impella, which I'm sure that some of you have used or have seen used and this is a device that not only is affecting all of these parameters. Actually, imagine in this room if we put a big hose in this room and we start pulling blood out of this room. That's effectively what that device is. So this is an Impella. So this device goes across the aortic valve into the left ventricle, and it pulls blood directly out of here. So if I pull blood directly out of here and eject it out the door, what will happen to the parameters we talked about? What will happen to afterload will potentially decrease, but one thing for sure will happen. If I pull blood out of here, the preload will surely decrease. So if we reduce preload, the left ventricular end diastolic pressure has to go down, right? So if the left ventricular end diastolic pressure goes down, that means that this line here gets lower, okay, and lower. So the gradient will increase. So the coronary flow will improve, okay? So if we improve coronary flow, it reduces ischemia. The pump is taking some of the work away. The pump can do about 3.5 liters per minute of flow on its own. So normal resting cardiac output, it can replace almost entirely normal resting cardiac output, which is 3.5 to 5 liters per minute. It can almost do all of that itself.